Welcome everybody to the Beginner's Guide to ACC for Nurses. We will begin with our ACC karakia. Fire, fire, fire to tika, fire to pono, fire to araha. Mo te aranga tangata, kia puta, ki te whae au, kiti au marama, homie, huie, taikie. For us, that means striving to do what is right, undertaking to act justly, being considerate of everyone that it may improve the lives of all. So welcome everyone. My name is Ellie Emerson, and along with my colleagues, I'll be presenting to you the webinar today. I'm an engagement and performance manager based in the Nelson region, and I'll just hand over to Mary to introduce herself also.
Kia ora everyone, my name is Mary Hyam and I'm an engagement and performance manager based in the Bay of Plenty, and I'm also a registered nurse.
Also helping us with the question moderating today is Lee. So thank you, Lee. We wanted to say a big thank you collectively for taking the time out of your busy clinical days. It is appreciated. We know it's pretty hectic out there, and we hope that you get some valuable information out of this hour. This is a new webinar format that we're developing as part of our pack, education pack for providers as new resources. We're going to be popping a link into the chat shortly, and we invite you to give us any suggestions or feedback that you have or topics that you would like to hear in future webinars. The webinar itself is aimed at being an ACC 101, I guess, if you like. So it's a fairly high level overview of the basics, a bit of a foundation about ACC. And our hope is that we will develop some other webinars that dive deeper into specific topics in the future. Many of you will have registered some questions when you registered for the webinar, and hopefully we'll answer all of those questions throughout the presentation. But if we don't manage to do that, we hope that the questions that are remaining will help inform us of future topics for webinars. So let's have a look at what we'll be covering today. You can see we've got 8 sections. Mary and I will interchange in presenting different slides and topics in these sections, and we will stop at various points to answer questions. So let's get started. What is ACC? ACC was established in 1974. It's a Crown entity and it's governed by legislation. We provide 24-hour no-fault personal cover for all of New Zealanders and for all of our visitors. So as you'll be aware, we look kind of different to many other countries, and it's quite a unique system. What do we do? In summary, we try and help prevent injuries, we provide rehab, and we financially support those that are injured through an accident. And to do that, we partner with people like yourselves to help us get our clients back to independence. How are we funded? Essentially, we all pay for each other. We all pay for the scheme and to keep the scheme running. As employees, there's a levy in your wages. If you're an employer or if you're self-employed or if you're a contractor, you will also pay levies. And for each of us, when we fill up our vehicles, there's a levy at the fuel pump, which helps go towards or contribute towards those accidents we have on our roads. For those of us that are non-earners, so that's our stay-at-home parents or our elderly, and the visitors to New Zealand are partly funded by our government. So I'll now hand over to Mary to take us through the next section.
Thanks, Sally. So I'm going to talk about cover and causation. So first of all, what is cover? So cover means whether a claim meets the criteria set out in the legislation and is accepted or not. Claims are either accepted, declined, or held. ACC requests further information for held claims to enable a decision to accept or decline. If the claim is covered, then ACC can consider funding assistance for that injury. such as treatment and other supports. It's a no-fault scheme for everyone and our visitors, so it's uniquely Kiwi. So what we can cover is obviously physical injuries that are caused by an accident, mental injuries. There are 3 ways that a mental injury may be sustained. May be sustained as a result of a physical injury, such as someone losing a limb in a traumatic accident, and then they go on to suffer depression, or it can be a traumatic event at the workplace, and that might be a bank teller who's had a machete held at their throat, and they then go on to develop post-traumatic stress disorder, or it can be the result of a criminal act such as sexual assault or abuse. We also cover work-related gradual process disease or infections, such as work-related hearing loss. Cover treatment injuries. So these are injuries caused by a registered health practitioner during the course of the treatment. It can also be a failure of equipment during the course of a treatment, but does not cover the normal consequence of the treatment itself. And from October last year, we are now covering maternal birth injuries. On our website, there is a list of the maternal birth injuries that we do cover. So when you get the slide deck, do click on the links on the slides that will take you straight to maternal birth injuries in that list. Thank you. What we can't cover. So ACC can't cover medical conditions, pre-existing developmental or biomechanical abnormalities, injuries that weren't caused by an accident. The example here is coughing, an internal force which causes a strain. Probably a more obvious example would be biting your own tongue. ACC doesn't cover conditions related to aging or injuries that happen over a long period of time, unless it's a work activity. ACC doesn't cover most hernias or sunburn. Also, when the ACC 45 comes in and the diagnosis is pain, like pain in lumbar spine, where there's no identifiable physical injury or accident event. So again, there's a link there to click on for more information about those. So we're looking at what is an accident. So the legislation is very prescriptive about what an accident is. There is always an injury event or a series of events, like an external force, which includes cutting yourself with a knife accidentally, or lifting a heavy object, twisting or pivoting on a knee to get out of the way of a heavy object. Series of events. This is something that usually happens over a defined period of time, and it's usually quite a short period of time, and it's usually related to unusual activity for that person, like digging in a garden over the winter, over a weekend, and they haven't dug the garden all winter, so the ground is very hard. Or it might be chopping firewood over a weekend when they haven't done that activity for a while, and by Monday their shoulder is very sore. So we don't know if the sprain occurred on the Friday or the Saturday afternoon or the Sunday morning, but that would meet the description for series of events. So an accident event can also involve something less obvious, like inhaling fumes that might lead to a hypoxic brain injury, or swallowing something. Children often swallow small objects. Swallowing a small battery would cause a lot of problems down the track if that wasn't picked up quickly and treated urgently. ACC does cover some allergic reactions, and as previously, if we've got maternal birth injuries are now included in there. So carrying on, cover. I won't go through the whole list. You're probably very familiar with the list of injuries that a person might suffer. I will just mention self-inflicted harm. ACC normally only covers the cost of the treatment of that injury. The person probably won't be eligible for weekly compensation. going to have some slides about causation. So causation means that the accident must have been caused by the injury. We need to be really confident it's more likely than not that the person's injury was caused by the accident. Causation is the link between the accident and the injury. Sometimes the initial symptoms of a condition coincide with an accident event. However, when you dig into it, the correlation isn't there. And this can be quite a complex thing. Like, we all think, oh, my leg is sore, I must have hurt myself, but we need to know what the event was. And there are some really good guides on our website too. The questions to ask your patient are, what were you doing? What went wrong? And what did you hurt? And that links the picture of what happened with this injury altogether. So we'll carry on now for some looking at some activities that lead to injuries or not. So here we have Gary running on a bush track on a peaceful Sunday morning. He tripped and fell, dislocating his left shoulder. So the activity was running, the accident was his fall, and the injury was a dislocated shoulder. So that's quite straightforward. And you've answered the three questions. What were you doing? What went wrong? What did you hurt? Look at another activity now. Jenny had a minor car accident and came into your practice for a check-over. The nurse practitioner examines her, no injury is identified, and Jenny went home. So if the activity was driving her car, the accident was a car accident, but there was no injury, so there's no need to fill in an ACC 45 and lodge a claim because she has got no injury. She might return in a day or so with a sore back that might have been, the pain might not have been evident. She might have been in so much shock that she said, oh no, I don't have any pain anywhere, and it came on. And at that point, you could consider looking at the injury event from the day before and to see if there was a correlation. But certainly people can be in accidents and not injure themselves. We have another activity. Chris was reaching up to hang in new kitchen cupboards when he dropped the drill, which landed on his foot. That night he noticed a large bruise. So the activity was some carpentry. The injury event was a heavy object falling on his foot, or the accident, and the injury was a hematoma on his foot. So again, quite a straightforward history and quite easy to see how it all happened. We'll have a look at another activity. Tom is stung by a bee and needs treatment for a severe allergic reaction. It's the first time he's had this kind of response. So again, his activity was outside playing. The accident was the bee sting, and the injury was the allergic reaction. A key point here is that ACC only pays for an EpiPen once it is used. ACC does not pay for spare EpiPens or those needing to be replaced because they have expired. Okay, we'll carry on. So at this point, I'll ask Lee if there's any questions that have come through.
Hi Mary, we've just got one question in this section. And what type of claims or injuries are nurses able to lodge or submit in their own right?
That's a great question. So nurses should lodge claims that are for injuries that are within their scope of practice to diagnose and treat. So a nurse could diagnose a laceration or a sprain because she can obviously see the injury and she can treat it quite independently. However, if someone came in and said they'd had a bang on their head and they had signs and symptoms of concussion, that would not be something that the nurse could diagnose. So always document in the clinical notes what the issue is. But if it's something outside your scope of practice, the patient needs to be referred to someone who it is within their scope of practice to make the diagnosis and plan the treatment.
Thanks for that, Mary.
Okay, so now we'll move on to lodging claims. So all of our claims start with an ACC 45, and the key point here is that making sure that all the information is correct and the details are complete as possible, and as much information as you've got as possible. And what that means for us is that we can get faster access to the correct treatment for your patient. Obviously, as Mary noted, the diagnosis has to be within your scope of practice, and we've just talked about the accident and the causation factor. So make sure that you're satisfied that that's there. What injuries to lodge? The key point is here that it's got to be a physical injury and it's got to be consistent with the accident. So you need to be satisfied that the accident has caused the injury. You may not necessarily know exactly what the injury is at the time that they present, but the mechanism and clinical picture that you have needs to be consistent with an accidental injury. It's not obviously appropriate that if you're seeing someone that has a shoulder injury and then they say, oh, and I've also got heel pain, it's not appropriate to then lodge a heel injury just so that you can get some ACC subsidised imaging, unless, of course, the accident mechanism means that they could have actually hurt their heel in the same accident. Next slide, please. Read codes. We often hear from nurses and GPs actually that finding the right read code is really difficult. So this slide is really about a couple of ways to make that easier. The common read codes used by injury type are readily available on our website. There's a little link there when you get the slide back that you can click on. And also, secondly, underneath is a handy little website that we've found that was developed by an Otago University med student. And it works essentially like a search field. You start typing in laceration, for example, and then it gradually filters down. So if you put laceration, it'll bring up all the laceration codes, and then you can put hand and it will filter down for as specific as you want it to be till you come up with the right read code at the end. Moving on to sensitive claims. Sensitive claims, I think the key point I'd like to make here is that you need to perhaps please discuss with your patient which pathway they'd like to take. When we lodge a sensitive claim through a nurse or a GP, we require a safe contact, because what happens when that ACC 45 is logged, it triggers a process where somebody may contact that person. So number one, if it's not safe to contact them at home, we need to know that if in fact the abuse is in the same home, occurring in the same home. And secondly, if it is safe, then we need to know the correct way to contact them. So but the point that I'd like to make here is that if you direct your patient through to the Find Support website and they can select a counsellor that way, they can lodge the claim in that manner through a counsellor, and then the ACC contact will be through that counsellor. And many of our clients find that that's preferable. So it's worth discussing with them as to which way they would like to go. If you are lodging the claim, you'll see on the top there that we don't need details. You can just pop in that read code and put sexual abuse in there, and that's all the information that you need, and we can take it from there. And I would encourage you all, if you haven't, to have a look at the Find Support website. It's a good resource that's out there for you to be aware of, that you can tell your patients. And finally, in this section, making sure our clients get the right cover. When we have a change of diagnosis, it's important that that ACC are notified. And having the right diagnosis means that we can therefore pay for the right treatment. And also that works both ways. If you start off with something that you think is a sprain to the knee and then it changes, then we need to know. If it starts as something more serious and turns out to not be as serious, or indeed not ACC related, then obviously we need to know that also. I'll hand now to Mary. Thank you.
Okay, thank you, Ellie. Supporting your patient. So I'm going to get into the detail of how to use the ACC cost of treatment regulations. So how we fund nursing treatment, it does include our other contracts as well, the rural GP contract, urgent care, nursing services contract, and there is a nursing component in the integrated home and community support contract. That's the contract that provides home help and personal cares. So the cost of treatment regulations is our non-contracted service, and it's used by 90% of GP practices in New Zealand. The cost of treatment regulations, the schedule is called the ACC 1520, and if you want to find it on our website, you can just Google ACC 1520. I'm going to talk a little bit about the cost of treatment regulations is divided into consultation rates and procedure codes. So the first part of the schedule is about the consultation rates. It includes our consultation money includes the cost of treating minor injuries and follow-up. There are higher rates for community services cards holders and under 14s. And just a reminder that the money in there is a contribution to the cost of the care. So most practices also charge the patient a co-payment. And then there's the procedure codes. Now, all the procedure codes start with the letter M, and that is for management of. The next letter in is kind of phonetic, like B is for burns and abrasions. MT is for soft tissue injury. And these codes can be claimed in addition when the injury requires a significant amount of time and or significant dressing. The way we define a significant dressing is that it involves moderate to high cost products or is a multi-layered dressing. Some people are quite allergic to dressing products, and all they can tolerate is some paraneck gauze and a pad and a bandage. So that's 3 layers, so that meets the criteria of a significant dressing. I'll give you some more information about how you can move around through the codes in the next slide. And some other tips for invoicing too. Just a note that when you are managing a wound, always think about what might also be affecting the time for that wound to heal. So is there a comorbidity? Is there vascular problems, diabetes? Is the patient self-harming? Those sort of things that might delay wound healing. If you are getting a wound that's taking a very long time to heal, consider referring it to one of our nursing services supplier holders. They do have Doppler and they can apply compression therapy to help that wound get quicker, heal up quicker. So tips for invoicing: always invoice the combined GP nurse consults under the GP's provider ID, and procedure codes should always be invoiced with a consultation code. Sometimes when we're looking at invoicing, we can see that there has a procedure's been billed for, but the consultation money has been missed out on. So make sure that if the procedure fits the description in the regulations and you're billing for it, that you capture both. Carry on. So we're going to have some break for questions at the end of this section. So if there's any questions bubbling up, we'll stop for questions at the end of this. So we're just going to go through some typical examples of what might present to you. So a community services card holder, we have 78-year-old rest home resident Molly. She walked into a coffee table and she's got injuries to both her lower limbs. You clean and debride the wounds, apply Steri-Strip to close a left-sided laceration and apply a dressing to a right-sided graze. You complete an ACC 45 using the red code for laceration, abrasion, lower leg. You claim an NCCS, which is the code for the community services card consultation now on the regulations, plus an MW1, plus an MB3. We'll pay 50% of the MB3 as a lesser cost. because if you've got more than one procedure, we pay 100% for the most expensive procedure and 50% for the procedures that are of lesser cost. Carry on. This is an adult with a simple injury. John stepped on a nail at work, resulting in a puncture wound on his right foot. You clean the wound, apply Band-Aid and administer a tetanus injection. You complete an ACC 45 using the read code for laceration of the foot. I've looked and there is not a read code for puncture wound of foot. But if anyone finds one, I'd be pleased to hear about it. So you can invoice us for the consultation only. The tetanus vaccine is covered by the Ministry of Health, and ACC bulk funds the Ministry of Health for the tetanus vaccine. So you can just take one out of the cupboard and it's been paid for. Now we have a child with an injury. So 5-year-old Nixon presents with a 1 centimetre laceration to his right knee. Clean and debride the wound, apply series strips to close the wound and a small dressing. You complete an ACC 45 using the read code for open wound knee. His claim will be for an NC 14 and an MW1. So you'll notice the MW codes are about the length of the wound. So it's less than 2 centimetres for an MW1, greater than 2 centimetres and up 7 centimetres for an MW2, and MW3 I think is greater than 7 centimetres. Another tip for when you've got an open wound is it's either greater than 4 centimetres squared or less than 4 centimetres squared. 4 centimetres squared is about the size of a credit card, so it's quite a good thing just to keep in the back of your mind when choosing the code to use. Carry on. So, Lee, are there any questions so far for these sections?
Yes, yeah, we do have a few questions. So the first question just relates to lodgement. So often we have patients who come into the practice and they've had their initial treatment at another health provider. So perhaps they've gone to the hospital or they've seen a physio, and when they come into the practice, they haven't had a claim lodged yet, or the ACC has no record of the claim. What should we do in that situation?
So this is quite a common situation because most public hospitals don't have a practice management system, and they have admin staff who lodge those claims with us in a more manual way, and sometimes there can be a delay of some days. So the best thing to do is to have a duplicate claim lodged at your practice. As long as you note on the ACC 45 that this is a duplicate, then we can marry them up when the hospital 45 comes in.
Great,
so
thanks.
it's really important. Yeah, sorry. It's really important to lodge claims in real time if you can, because otherwise we don't know about the patient and their injury.
Awesome. So next couple of questions are in relation to wound dressings and wound care. So if a patient is coming in for follow-up wound dressings, does a GP always have to be involved in that consultation, or does the GP have to see every wound dressing change?
This question comes up quite a bit too, and it's what I advise is that every practice has their own clinical governance set up. And if the clinical governance in your practice is that the GPs want to see all the wounds, then that is what happens in your practice. But also out in the community, there are some nurse-only clinics, and the nurses are lodging the claims and treating the wounds independently. So you've really got to think about what is the clinical governance, and what are the rules around managing these clinical situations at your practice.
So if the GP and a nurse do see the patient at the same time for the wound dressing change, how do they document that?
that's also a very good point, Lee. Both practitioners must write in the clinical notes, and both must spend a reasonable or significant amount of time with the patient in order to claim that combined GP nurse consult. So yeah, both must write in the notes that they both attended in that consultation.
So it's always more than just a GP popping their head around the door to do a quick look.
Yeah, absolutely.
And the last question we've got is for a wound that requires closure and then the patient has to come back for follow-up dressings, which codes do you use in that circumstance? When do you use an MW code and when do you use an MB code?
So the MW codes are for closing open wounds with glue, steri strips or sutures. So that's known as primary intention wound healing. You get the two edges together and glue them together, and hopefully that will heal the wound and all will be well. So that's, you use the MW code then. If the patient comes in for a follow-up and all they need is their sutures removing, all that can be claimed is the consultation price. However, if the patient comes in and the suture line or the steri-stripped area is inflamed and obviously infected, the sutures or glue or steri-strips need to be removed, and then you are healing that wound by secondary intention from the bottom up and the sides in. And for that dressing situation, you use the MB code relevant to the size of the wound. So MBs 1 and 2 for treating burns, MBs 3 and 4 are for treating abrasions, which is in the regulation speak is for treating an open wound.
Thanks, Mary, that's really helpful.
Thank you.
Okay, so moving on to clinical records. So clinical records obviously need the detail of the accident, the injury. You need to record the diagnosis, a claim number, describe the injury impact on the client, and you have to have informed consent to lodge a claim for our patients. I think the important thing I'd like to mention here is that informed consent can be verbal. So if you're wanting to get away from paper, or if your patient doesn't want to fill out a paper form, if you verbally discuss the consent with the patient and then document that in the clinical notes, then that takes the place of a piece of paper, if you like, and the patient doesn't need to fill out a form. The notes obviously need to, as Mary alluded to before, they need to show what happened, the accident and the causation and the injury. Moving to the next slide. This slide talks about your treatment plan, and I guess what I'd like to say here is that ACC provides treatment and support in relation to the injury and based on the information that you as a provider give us. So you need to be clear in your record keeping about what is impacting the patient, what they can and can't do, what supports are needed, what's impacting them, and what the effect of the treatment or any treatment that you've provided, what that has been. We often see things like tolerated well in clinical records. That doesn't actually tell us how effective the treatment was. We need clinicians to be specific about the treatment that's provided and think about, could somebody replicate the treatment based on the notes that you've written if they were to just read your notes? So we're looking for rationale and timeframes, the intention of what you were doing. Essentially, that is good clinical practice. And the reason that we find it so important, that it is so important, is that we find sometimes a client will come back to us in weeks or months even, and they're looking for support. Now, we need to go back to the contemporaneous medical notes. So we're relying on what was said at the time that the patient presented. So the more information we have, that will support the patient should they have a need later on. And that could be for things like surgery, it could be for home help, it could be pain management, support at home, could be a whole variety of things. The other reason that we look at your clinical records is that sometimes in ACC, we are looking to make sure that treatment that has been provided and invoiced for is necessary and appropriate and meets the expectations meets our expectations. And we have quite a sophisticated, what would you call it, a system in the background for overseeing treatment and invoicing patterns. And so we may contact you at any point to check out how your invoicing looks. And to do that, we marry that against what you've invoiced for and what was recorded in the clinical notes. So it's important that these are accurate. Moving on to position statements. ACC have developed a variety of position statements that align with professional standards and marry up with our legislation. They're really there to guide you and explain what you need to do and what you need to consider in different circumstances. It's important that you take the time to read through these, as you'll need to document your actions and rationale in clinical notes. You'll see there on the right-hand side of that slide, there's a lot of different position statements. Now, some of them obviously won't apply to everybody in every setting, but they're handy for you to understand and know. I'll now hand back to Mary to talk about getting set up and paid.
Sorry. Right. Registering as a provider. To work with us as a provider, you need to have an ACC provider ID. So there's a number of things that we need. And we do know that most of you on the call today will be, or on the webinar today, will be already registered with us. But if you are registering on someone else's behalf or someone asks you, there are these key things that you'll need to have. So there are some fly-ins coming in. We need to know your health. You need to complete the ACC 24. We need a unique email address for you. We need your HPI. We actually check your annual practicing certificate online, and your health practitioner's index number enables us to do that. Then we submit and verify your email address. So once we have all the information, we'll confirm a number for you within 1 to 2 days. It's quite quick. We'll move on. So if you're a nurse who is updating your registration from nurse to nurse practitioner, we need to update your scope. And the quickest way is to contact the ACC registration team by phone or email, and we'll confirm with the Nursing Council to update our details. So it's an important thing because as a nurse practitioner, you're able to provide medical certification for us, which is a very useful thing to be able to do in general practice to help out with the workload that happens. So we'll move on. We do have provider locum numbers. So if a nurse is coming into the practice for less than 3 months, the practice's locum number can be used. If the person is going to be staying longer than 3 months, it's better that they actually get their own number. And a key thing to think about is that your ACC provider number is attached to the bank account of your practice. So if you're working at more than one practice, you can't take that number with you because the invoicing that is under that number will go into the bank account of the account that's attached to your number. So just keep that in mind if you're going to work somewhere else. So new health providers working under your locum number need to complete the ACC 5935. This is so we can keep track of who's using the number at any point. I'll hand over to Ellie for talking about digital services.
Okay, digital services, obviously the key point really is that signing up will help make things faster and easier. As Mary mentioned before, every practice will be different, and it may be that you have, as a nurse, you don't have anything to do with digital services, but if you're one of the group on the call today that may be working alone or in different sort of circumstances, then it's important that you are aware that this is available out there. And there's a link in the slide pack here. So if you were wanting to get set up, then you just click on that link and it'll give you some instructions. But it definitely makes things faster and quicker, including payments, lodgement, all of that sort of stuff. Getting paid and invoicing. When to invoice: within 2 months, but within a maximum of 12. For treatment injury, it's from the date that the injury was determined. So the date that your patient came in to notify you that something had happened. What to include: obviously, all invoices need to meet the Inland Revenue standards and include the ACC 45 number. And how to submit: you can submit through online services or through your practice management system. We generally take about 8 days to pay invoices that are submitted electronically. This slide we popped in as there was a question at registration about how we work at ACC. So just to give you a very basic overview, we have 4 sort of streams of work at ACC. As you can see, it starts from enabled recovery, which is pretty low touch. It's the things like that we use a My ACC app, and those clients can order things online like equipment or taxis. They're largely self-managing. Our assisted recovery team is a one-to-many approach, so you won't have a one-on-one relationship with one of our team members, but you will have a group of team members that can meet all of your needs. If your injury requires that you're going to be off work for a bit longer and you may need a higher level of support, you will work with our supported recovery team, where you have a one-on-one recovery coordinator. And finally, the last group of clients is our partnered recovery team, where you will have a recovery partner, and they usually are more complex claims that are off longer. For some, they will be off for life, like our seriously injured clients. And then separate to that is we have an administration team who do all the support for our recovery team members. So they do things like purchase orders. They might be the ones that you have contact with in terms of requesting medical notes or purchase order updates, things like that. One of the key points is that clients can move within teams throughout their recovery journey. So if it may be thought that they had a relatively simple injury, so they would be in one of the first 2 streams, and then there's a complication. So that would mean that they might swap to one of the other, so they can move within that structure. Okay, back to you, Mary.
So resources. We've developed some great new resources and updated our website. So that's hopefully going to become a go-to area for you. We've got easy to use quick guides, including being mindful about mental injury and great information about lodging those claims, how to use read codes and how to register as a provider. There's an introductory video to get you started with some basics about what we do and how we'll work together. And webinars like this one that are tailored and talk directly to providers. These cover the basics of working with us and will include more information over time. There's plenty more to learn, and we're always developing new resources. Our online learning modules are useful for any level of experience or role. So here are some contact details that you might find useful. The provider helpline in general, billing is provider help email and the 0800 numbers there. Provider registration, there's also the email address for GP and nursing portfolio, the 0800 number for electronic billing inquiries, and the e-business info email address for you. And another, finding what you need through that last link there. And also links all throughout the slide deck. As I said earlier, when you get the slide deck, please do click on the links. They are quite safe and you'll be able to find the information that you need quite quickly. So any further questions at this point, Lee?
We've just got one final question around registering with ACC as a provider. So in a residential care setting, does each of the nurses need to have their own individual provider IDs?
Yes, they do. This is so that we can link that provider to that care for that time. So it's like, you know, you don't lend your driver's license to anybody. You need to not share your ACC provider number either. Yeah. And it's quite a quick process, as I outlined, so it would be great for all the nurses who are going to be providing ACC care to have their own number.
And also, if I can just add, Lee, that if you are lodging a claim, you need to put your provider number in there, so you will need a provider number for yourself in order to lodge a claim.
It's a great reminder for everyone. Thanks, Ali and Mary.
So what's next? So we really want your suggestions, and we'd love it if you could take a minute after this webinar to let us know your thoughts. We're particularly interested in what your thoughts are about the format of this webinar, what you liked about it, and how it could be improved for the future. Please also let us know if there are other topics you'd be interested in hearing more about. Simply click on the link in the chat and share your suggestions with us. Next slide. Over to you, Ali.
Great, thanks, Mary. So once again, thank you so much for your time to attend. I know that it's a busy time out there in general practice, so we appreciate your support, and we'd just like to close with the ACC karakia. Whaia, whaia, whaia te tika, whaia te pono, whaia te aroha, mo te oranga tangata, kia puta ki te whaeau, ki te o marama, homie, hui e, tai ki e. Thank you, everyone.